Hi, my name is Andrea Servas, and today I will talk about my teaching plan about educating young adults with newly diagnosed hypertension. Here is the table of contents. First, I will talk about analysis. So, the target audience is adults newly diagnosed with hypertension, focusing on younger adults age 18 to 39 because this group has the lowest awareness, treatment, and control rates. Their key learning needs include understanding hypertension, adhering to treatments, making lifestyle changes, and learning proper home blood pressure monitoring. So, younger adults often experience limited prior health education and need flexible, accessible learning options. They are diverse in background and prefer digital on demand formats. Teaching will be provided through a hybrid model, in person clinic session, and device friendly online modules. To accommodate learning needs, I'll start by assessing readiness and validating feelings to build trust. Teaching will be multimodal and patient centered, adapting to different learning styles and literacy levels. All materials will use plain language, visual aids, translated resources when needed, and replace jargon like hypertension to high blood pressure. Also, cultural relevance will be ensured through appropriate diet examples and respect for traditional practices. To support different learning styles, for visuals, we have videos, infographics, dashboards, and live demos. For auditory, there's verbal teaching, podcasts, narrated slides, and Q&A. For reading, writing, there's handouts and downloadable guides. For kinesthetic, there's hands-on blood pressure monitoring practice and interactive quizzes. The teaching will optimize web based teaching for various devices like phones and tablets with low tech alternatives like handouts or phone follow up. The digital resources will use clear, adjustable font sizes, high color contrast for readability, and include captions for all videos and audios. The web based platform allows learners to control their pace, like pausing, rewinding, or skipping as needed, giving busy young adults the flexibility to engage with content on their own schedule and learning speed. Now I will talk about development. The teaching content would include basic hypertension information like its definition, risk, and complication, home blood pressure monitoring, explaining its benefits, choosing validated cuff, demonstrating proper techniques, and how to interpret and log readings, and when to contact their provider. Medication adherence and lifestyle factors are also addressed, like following DASH diet, increasing physical activity, moderation, alcohol use, smoking cessation. My teaching approach uses a blended patient centered method. First, we start with clinic education for about 40 minutes. This includes 10-minute pre-test, 20 minutes introducing the interactive e-modules and teaching content, and a 10-minute post-test. Next, we have 20-minute in clinic demonstration. The nurse demonstrates proper BP measurement, the patient performs a return demonstration, and we use teachback to confirm understanding. Research shows that teachback improves patient understanding and retention, while return demonstration builds skills, increase competency, and help identify learning gaps. We also use interactive e-modules, which are 10 to 15 minutes H5P modules covering content topics like BP monitoring, diet tips, and medication adherence. It also has quizzes to provide feedback and track progress based on the content. These modules increase engagement and support self paced learning, but they are adjunct to hands on teaching, not a replacement. For patients without digital access, we also provide low tech alternatives such as paper logs and handouts, along with phone follow up for reinforcement. Now I'll discuss how the teaching plan will be evaluated. First, knowledge evaluation. We'll use pre and post questionnaires during the initial nurse education session. This will include hypertension knowledge level scale and Medline plus BP and lifestyle quiz to measure what patients learn. We'll also collect digital learning data from the H5P interactive modules. The short quizzes built into the module capture immediate post module scores and completion rates. These analytics help identify which topics may need more reinforcement. Next, the skill evaluation. After the in clinic demonstration, patients will perform home BP monitoring while the nurse evaluates them using a 7 item skills checklist shown in the left. A score of 6 or higher means the patient is competent. The skills check will be repeated during the initial session and again after the first follow-up, either in clinic or by phone. Also, behavioral and clinical outcomes we will track each patient's home BP data to monitor progress over time. Specifically, we'll look for a change in mean systolic BP after 3 months and measure percentage of patients who achieve their target BP. This teaching plan is guided by two main learning theories. First, cognitive learning theory, which focuses on helping patients understand and apply information, not just memorize steps. In this plan, patients learn to interpret their own BP readings and apply the knowledge to daily life. Tools like pre-test and post-test, interactive e-modules, and teach-back activities help reinforce comprehension, recall, and critical thinking by combining hands-on demonstration with patients actively engaged with materials, which supports retention and helps them transfer the skills to real-world self-care. Next, we have humanistic learning theory. This theory emphasizes that learning happens best when it's self-directed, emotionally supportive, and personally meaningful. In this plan, the nurse begins by assessing the patient's emotional readiness and acknowledging their concerns before teaching. Patients are also encouraged to set personal goals, such as improving diet, increasing activity, or managing stress that align with their values and motivation. The blended self-paced format supports autonomy and efficacy while trusting and non-judgmental nurse-patient relationship helps create a safe and empowering learning environment. Next, I'll talk about its implementation. The program will be implemented in a primary care clinic where most adults are first diagnosed with hypertension. Initial education will take place in the clinic right after diagnosis, followed by supplemental session that can be completed online through H5P modules or with printed handouts. There's also an optional telehealth option for video or follow-up to reinforce learning. The initial session is accessible immediately after diagnosis, and the supplemental education is available anytime, allowing patients to review materials at their own pace. During the ongoing follow-up visits, nurses review skills, quiz results, lifestyle changes, and BP logs to monitor progress. The primary facilitator will be a registered nurse or nurse educator. They'll be supported by an interdisciplinary team that includes dietitian, pharmacists, physicians, and IT or administrative staff. The resources needed will include tablets or laptops for video demonstration, access to H5P e-learning modules, BP monitor device, and reliable internet. Educational materials include plain language handouts with visuals like HBPM steps, dash diet tips, and BP logbooks, including translated version for accessibility. The session will take place in a private education room with sitting and power outlets for demonstration. The initial session will take about 1 hour to 70 minutes. The implementation steps include Step 1, prepare educational materials and train staffs. Timeline is 1 to 2 weeks. Step 2, identify and schedule patients. Weeks 3 to 4. Conduct 60 to 70 minutes nurse-led session. Weeks 4 plus. Self-paced online modules learning. Weeks 4 to 8. Step 5 is reinforce and follow up a scheduled visit, weeks 8 plus, and step 6 is evaluate and collect feedback, which timeline is 3 to 4 months. Next, I'll talk about the self-evaluation of the teaching plan. So its strengths include the use of multimodal, nurse-led approach that supports different learning styles and builds patient confidence, its adaptability to literacy, language, and cultural needs, and the blended format offers flexible self-paced learning. Also, using validated tools like hypertension knowledge level scale ensures measurable outcomes. It's also accessible and sustainable with both online and paper option and encourages team collaboration among nurses, dietitian, and pharmacists. For the areas of improvement, includes some patients face digital barriers or have limited access to technology. Clinic time can be tight for comprehensive session. Cultural adaptation can be complex. Also, online modules provide less immediate feedback than live instructions, and data collection analysis requires extra staff time and coordination. So that concludes my teaching plan presentation. Thank you so much for listening. The following slides are the references.